to start. I just need to introduce Julien. I don't think he needs a lot of introduction, but Julien Potet has been working with Médecins Sans Frontières Access campaign since 2011, where he's senior advisor for the NTDs, with a particular interest in lots of diseases, leishmaniasis, Ebola, rabies, and snake bites. And before joining MSF, Julien worked with several NGOs as an HIV treatment program manager. And as probably half of the audience, Julien is also very afraid of snakes.
Thank you. Thank you very much for the introduction, and thank you. It's an honor for me to present today. So before starting the presentation, just a quick brief, a few words on what MSF does on the ground against snake bites. So we treat throughout the different hospitals that we support approximately 7,000 cases of snake bite every year, particularly in East Africa, a little bit in West Africa, and in the Middle East. And about half of these patients need antivenom therapy that we provide free of charge. So that's the big picture. My speech is going to be more or less about what MSF does on the ground. It's going to be more about, generally speaking, access to antivenoms in low and middle income countries, and a presentation of the different experiences and challenges. Before we start, maybe, I don't know if it's, can I use that? Oh, sorry. I think you put that in there. So the organizers asked us if we could have some sort of mini service during the presentation, and I wanted to ask a very simple question to people who are on Zoom and people in the room. So the question is to participants online or in the room, in your country or in the country where you work, with or the country with which you collaborate, how would you describe the situation with regards to access to antivenom therapy? Access to effective antivenom in your country or in your country of interest is very good, good, limited, and very limited. Let's have a show of hands in the room, and maybe people online can explain how they can. They're already doing it online, but let's do it in the room. Access to effective antivenom, very good. Okay, not many. Good. Limited. And very limited. Okay, I think it's yeah, something like 15%, 20%, and then 35, 40, or maybe that's a bit too much now, but 30 or 35, something like that. So I think there's a majority of limited and very limited in the room, and we'll see what happens on the poll. On the poll, so 33 people have answered, and maybe you can show on the screen the results. Okay, but I will tell you. So very good access, 12%, good access, 30%, limited access, 33%, and very limited, 24%. It's pretty much the same thing as here in the room. So I think we have a majority of people who think that in their country or in countries of interest, access to antivenom is not optimal for sure. Okay, so the findings and recommendations that I'm going to share were actually published 2 years ago in a special issue of Toxiconex. You can see on the slide the reference for the publication. So it was a work that was done with many different co-authors from different regions of the world, and the purpose was to be really multidisciplinary, like was said in the introduction. So we had an expert in anti-serum production, in clinical care, in health policies, in epidemiology, in supply chain management, just to cite a few. And in our publication, our objectives were to list and to review all the possible barriers to access to safe and effective antivenoms at the global, national, and subnational levels. We wanted to also to recommend concrete solutions to overcome these barriers. So the first thing we did was to list the most important research questions, and you can see them here. The questions follow a framework that was previously used for access to insulin. So we were inspired by this framework. The framework looks at 3 different stages of the journey of an antivenom product, from the manufacturing site to the bedside of the patient: upstream, midstream, and downstream. The upstream stage corresponds more or less to the international level, the midstream stage to the national level, and the downstream stage to the local level. I will not read the questions now, but I will come back on several occasions to that specific slide. So for each group of questions, we gathered and reviewed some literature, including gray literature, but our final manuscript cannot be described as a systematic review. It's best described as an expert opinion review. So let's get started. Let's have a look at the first level, the upstream stage. We will analyze issues related to the manufacture of antivenom products. And the very first questions we asked ourselves were the following ones. Do antivenoms exist for all medically important snake species? Is the global antivenom manufacturing output sufficient to cover needs? What is the typical profile of antivenom producers? And are there many substandard antivenom products in the markets of low and middle income countries? Before looking at these individual questions, I think it's important to note that antivenom products, as you probably know, are very peculiar, very specific, and they have very different characteristics from other pharmaceutical products, including other biological therapeutic products. Antivenom products are bespoke or tailor-made pharmaceutical products that are specific to a limited range of venomous snake species. Sorry, that's not the right slide. So they are tailor-made and bespoke pharmaceutical products. And as you know, there is no universal antivenom. There are multiple products for different regions of the world. So if we look at that from an economic and industrial perspective, there is no such thing as a global antivenom market. Instead, the global antivenom market is fragmented into many different sub-regional markets that have their own dynamics and are delineated according to the geographical distribution of medically important snake species. So since antivenoms are bespoke pharmaceutical products that are tailored to a given region or country, it is not a surprise that the global supply of antivenom actually relies on a lot of small suppliers around the world. This map lists the countries where there is at least one antivenom producer. Approximately 2/3 of the listed antivenom producers in this map are public institutions, not private companies. Many producers listed here just make antivenoms for their own countries or the neighboring countries, but no more than that. And if you look at the number of public and private firms that produce antivenoms, not just for their regions, but for other regions of the world, this number is very limited. This map also shows that there are no antivenom producers in certain regions of the world. The most striking example is Sub-Saharan Africa, where there is currently only one antivenom producer based in South Africa. In addition, the antivenom producer in South Africa manufactures products primarily for its domestic market, and only limited amount of vials are actually exported to other countries in the region. Similarly, Nepal, another country where the burden of snakebite is high, depends exclusively on antivenoms produced in India. This leaves the country in a situation of vulnerability. In 2012, Nepal suffered an acute shortage of antivenoms after India decided to ban exports of antivenom products because supply was at the time constrained in India itself as well. You're probably aware of that. It's important to know that antivenoms that are available in a given region do not always match well the medically important snake species in that region. A very good example of that is in India, in Bangladesh. All antivenom products marketed in the Indian subcontinent actually follow the same model, that is to say that they are specific for the big four species, Bungarus caerularius, Naya naya, Echis carinatus, and Daboia risale. But there are many more venomous snake species in the region, and it's often unclear if the existing antivenoms are able to protect against these other venoms through paraspecific activity. For example, it was recently demonstrated that existing antivenom in India are poorly effective against snakebite envenomations by important species like Naya caothea or Hypnale hypnale. The situation is particularly problematic for the east and northeast of India, as well as Bangladesh, where Naja caothea is known to inflict a lot of bites. Then we tried to estimate the global antivenom output. But I'd like to make an important point first. The number of antivenom vials is one thing. It may be relatively easy to estimate it, but the number of effective antivenom treatments is much more difficult to estimate. Because as you know, the mean number of vials that are needed to treat an envenomation varies a lot from one product to another and from one bite to another. The experts in our group believe that the dosages recommended by the manufacturers should be taken with a grain of salt and are often based on very limited preclinical and clinical evidence. So with these caveats in mind, we looked at a few publications from the recent past, and we found a survey in 2011 that estimated that the national production of antivenoms intended for use in India had reached the equivalent of between 100,000 and 400,000 treatment courses, while in India itself, there are between 1.1 million and 1.7 million cases every year. Similarly, a survey in 2020 by the Global Snakebite Initiative obtained data from 22 producers and estimated that 6 million vials or ampoules intended for low and middle income countries are produced annually. This equates to less than 1 million treatment courses. This is far below the 2.7 million cases of snakebite envenoming requiring antivenom therapy every year around the world. So based on these different estimates, we are fairly confident to claim that the annual global antivenom output is insufficient compared to needs. Then the other important question that we asked ourselves was about antivenom quality and the marketing of substandard products. It's a difficult and long question. It would deserve a speech in itself, but to keep things simple, we agreed among the group that there are many different situations, but generally speaking, our expert group thinks that antivenom markets are poorly regulated in several regions, as was indicated by David in his presentation. The good news is that the WHO has nearly completed an ad hoc assessment of antivenom products for use in sub-Saharan Africa, and another assessment is underway in the Middle East and in South Asia. In addition, over the last years, several anecdotal reports and post-marketing observational studies have pointed towards the marketing of completely ineffective antivenom products, particularly in Africa. In most cases, the incriminated product had been brought to market without any clinical data, and even in some cases without any preclinical data before approval. A review in 2019 found that among 16 different antivenoms intended for use in sub-Saharan Africa, only 3 had been evaluated through robust clinical studies. For several of these products, it was only during the use in the field that cases of poor clinical response became obvious. Finally, one clear example of fabricated regulatory data was recently revealed by a civil society organization in Ghana, and it suggests that antivenom procurement rules had been violated in that case. So it was the upstream. Now let's look at the second level, the midstream stage, and different questions. Why are not antivenom products procured at country level necessarily the most adapted ones and effective ones? What are the mean prices for antivenoms? Are antivenom cost effective? And who pays for antivenoms? And does this lead to catastrophic health expenditure? So antivenom products are not always registered properly in the countries where they are used. In countries where there exists a national manufacturer, the products are generally fully registered and distributed correctly. But the situation is different for countries that need to import antivenom products from abroad. For example, the South African product that I mentioned earlier, which represents a good treatment option for Central Africa and Southern Africa, is not registered in any other country except South Africa. It can only be imported into these countries through an ad hoc import waiver process. In the absence of proper registration, a procurement agency may mistakenly import products that are not meant to be used in their regions. The situation has been documented on several occasions. For example, in Ethiopia, the antivenom that was purchased by the National Procurement Agency until recently was a polyvalent antivenom product made in Egypt and meant to be used against Egyptian snake species. It was definitely not a good match against the predominant species in Ethiopia. This example is a bit extreme and does not necessarily reflect the different situations in other countries. However, compared to other pharmaceutical products, our expert group had the feeling that it's more difficult to follow good distribution practices for antivenom products. The risk is high that substandard products are imported in countries in need, including products that are not meant to be used in this geographical region. Okay, now let's have a look at the prices and costs. But once again, I'd like to reiterate that our metric should not be the price per vial. Our metric should be the price per effective treatment. In other words, both the price per vial and the number of vials that constitute an effective treatment should be taken into consideration. But like I said previously, it's often very speculative to use the dosages recommended by manufacturers to determine the number of vials that constitute an effective treatment dose. Ideally, some real cost-effectiveness studies would be available, and they would help procurement agencies at country level to make the right decisions. But unfortunately, there are very few cost-effectiveness studies, and health authorities in many countries very often struggle to compare objectively the prices of the different products that are available for procurement. In addition, in many low-income countries, payments to access antivenom come directly from the pockets of the snakebite victims. There does not exist any national financial mechanism to pay for antivenom access. There are exceptions, but when these exceptions exist, like in Burkina Faso, for example, the financing scheme that can subsidize access to treatment is difficult to access for the whole population. It was found in Burkina Faso that only 4% of snakebite patients were able to access this financing mechanism to get access to subsidized treatment. Under these conditions, it is not a surprise that snakebite victims may have a preference for products with a lower cost per vial, regardless of the true effectiveness of the product. We tried in our paper to review the cost and affordabilities of antivenom products in resource-limited settings. Unit prices of antivenom products, that is to say the cost for one vial, are extremely variable, but generally speaking, these costs represent a large share of the wages of snakebite victims. For example, in Kenya, it was shown that one vial of antivenom costs the equivalent of 14 days of the mean wages for low-level workers. Other papers have tried to look at the average cost of an effective treatment course in sub-Saharan Africa. Estimates vary quite a bit, but a recent survey by the Global Snakebite Initiative estimated that an effective starting dose would cost $463. Since snakebite affects primarily impoverished communities, this amount of money may be, of course, unaffordable for most victims. And finally, there are actually multiple reports from different regions of the world of catastrophic health expenditure as a consequence of treatment of snakebite envenoming. I don't know if you're familiar with the concept of catastrophic expenditure, but they refer to payments that can bring the family of the patient further into debt and poverty. These catastrophic expenditures can be caused by the high prices of the antivenom products, but also by the hospitalization costs. For example, a study in Sri Lanka found that 18% of snakebite victims who paid for their treatment found it necessary to sell stored crops, 14% had to sell valuable items, 9% had to sell cattle, and so on and so forth. And even a small number of people found it necessary to remove their children from education and to send them back to work. So once again, we need to keep in mind that situation can be very diverse from one region to another, but in certain countries of sub-Saharan Africa and South Asia, out-of-pocket payments can be a very serious obstacle to access to effective antivenom. Finally, let's look at the downstream stage and what happens at country and district level. You need to tell me how much time I need to, 10 minutes or something? Here are the questions that I'd like to ask. Are antivenoms available and in stock in the health facilities visited by snakebite victims? How can we plan and model and optimize geographical access to antivenom? Do healthcare workers use antivenom therapy rationally? And does traditional healing hinder prompt access to antivenom? Snakebite is a condition that affects predominantly rural communities, as you know. However, at the same time, in many countries, antivenom is restricted to facilities staffed by doctors because they need to be administered by professionals that can potentially deal with the complications such as adverse drug reactions or local tissue injury. So this leads to a situation where antivenoms are offered in facilities that may be geographically quite far from where the patient was bitten. Delays in transporting victims to the nearest hospital where antivenom is available is a major problem. An extreme example of the situation is in the Amazon region in Brazil. Some publications have described the itineraries and the different means of travel that the victims need to use to reach facilities by water, by land, and even by air. In other settings, the lack of roads and infrastructure can sometimes be overcome with simple measures, such as the implementation of motorcycle ambulances in Nepal. Efforts have been made to decentralize antivenom access in smaller health facilities, including primary health centers. But there's a whole debate in the snakebite community about whether it is a good idea or not. In Nigeria, a hub and spoke model has been proposed, whereby primary health facilities managed by nurses are equipped with antivenom and can refer victims to larger hospitals in case specialized care is needed. But for a model like that to be effective, major efforts are needed to train frontline healthcare workers on the management of snakebite and on the management of adverse reactions to antivenom. In addition, important point, it's very important to communicate clearly to communities where antivenom can be found. A publication in Nigeria reported that the vast majority of snakebite victims in the region of Donga were simply not aware that antivenom was available at the city hospital and couldn't reach it for that reason. These different examples show that it is difficult to optimize the geographical distribution of antivenom in a given province of a given country. The use of geographic information systems, or GIS, may be of great help. GIS systems can be used to measure physical accessibility to health facilities, it was mentioned in David's speech, to model the vulnerability of the different communities, and to plan antivenom and distribution networks. One of the first studies of that sort was done in Costa Rica, where GIS mapping has been used to identify areas in need of improved access to antivenom. Such systems can optimize the list of facilities storing antivenom and reduce the time to reaching a facility where antivenom is available and good quality care is provided. But reaching a facility where antivenom is offered does not, however, always mean that antivenom will be available in practice. There are numerous examples of antivenom stockouts in facilities that have been reported in many different settings. A survey in Kenya, Uganda, and Zambia in 2018 found that antivenom was in stock in less than 1/3 of the facilities where it is supposed to be available. Similar reports of stockouts have been published in Vietnam and Laos Republic, for example. It would be important to understand the factors why the risk of stockout is so high for antivenoms and potentially higher than for other essential medicines. I think it may be due to the fact that some health facilities want to store only a small number of antivenoms vials at any given time for fear that this expensive pharmaceutical product may expire unused and wasted. So they place small orders, and if they place small orders and have smaller stocks, the stock can be more easily depleted. Generally speaking, high levels of irrational antivenom use, and particularly underuse and underdosing, have been reported in several publications. For example, studies in the Amazon region of Brazil found that more than 50% of the cases with severe Bothrop's envenoming received underdosed treatment. And in countries where antivenom is paid by patients themselves out of their pockets, the situation can be even worse. In northern Cameroon in the late 1990s, one vial of antivenom was the equivalent of 4 months of food for a typical farmer. And underdosing became the norm under these conditions because farmers could not afford more than 1 vial, and even in some cases, they could only afford half a vial. Another possible factor for underdosing and underuse is the fact that many healthcare workers have lost confidence in antivenom therapy in countries where ineffective antivenoms have been in the market for decades. And in addition, several surveys in Africa and Asia have found that the basic knowledge about snakebite management, antivenom use, and management of side effects was rather poor among healthcare workers. Some health professionals may feel that they are poorly trained to manage correctly cases of snakebite envenomings, and they may prefer not to offer antivenom therapy for fear that they could not manage the severe adverse reactions if they happen. And finally, at the community level, many snakebite victims have a preference for traditional healers before seeking treatment from modern healthcare facilities. The choice of traditional or face healers ahead of allopathic medicine has been shown in many different cultural settings. It should, however, not always be interpreted as a mistrust of modern medicine, and there are examples of engagement with traditional healers that can encourage prompter referrals to a healthcare facility that has access to antivenom. So I will not read all these recommendations, don't worry, but what needs to happen? And our group of experts wanted to issue concrete recommendation. I will just give you the big picture. Number one, we think that there is a need to build up global and national capacities to better regulate antivenom markets. And the WHO has a pivotal role to play to assist endemic countries, as was described by David before me. Number two, procurement of geographically appropriate and effective antivenom needs to be improved. Pooled procurement between groups of countries in a given subregion could be a good option to obtain better prices. And we also recommend the establishment of a proper multi-country stockpile of quality antivenoms in sub-Saharan Africa to tackle the access and supply crisis in the region that has been going on for decades now. Number three, the antivenom supplier base needs to be strengthened, and collaborations between producers within regional networks could be helpful to facilitate the sharing of reference venoms, to mutualize some other costs, and also to develop new antivenoms for species that are not well covered by existing antivenoms. In that sense, there is a network like that already in Latin America, whereby different manufacturers in the region share the experiences and expertise, and this could be a good source of inspiration for other regions of the world. Four, it's important to boost the demand for antivenom at community level. We know that many people need antivenom, but demand is a different story. Demand means that they request access to antivenom in a facility. In order to boost demand, it's important to educate communities about antivenom therapy, but not only communities, also traditional healers and frontline healthcare workers in order to foster demand for antivenom. People need also to know very well where antivenom can be available in their countries. And because cost is a problem, out-of-pocket payments should be suppressed to access antivenom. And number five, antivenom distribution at country level can be improved. GIS mapping systems can optimize the geographical distribution of antivenoms. And with proper training, it is possible to decentralize administration of antivenoms in small dispensaries and other primary healthcare facilities. So there's still quite a lot of work that needs to happen, and this is a global strategy against snakebite that was quickly presented by David. Unfortunately, these many of the recommendations that we make are addressed within this global strategy, but unfortunately, very limited funding so far has been mobilized for this roadmap. So our most important call is to mobilize resources for that. So I thank you for your attention, and I'd like to thank the different co-authors of my publication. It's been a pleasure to work with all these different experts from different regions of the world. Once again, it's difficult to learn lessons that can be applicable across all these different regions. There are very different situations, but still we tried our best to describe the common features of the problem of antivenom access in low and middle income countries. So thank you for your attention.
Thank you very much, Julien. Any questions from the audience here?